So, good morning everyone, and thank you for joining us to the educational seminar ambitiously titled Integrative Rheumatology. You have inspired it with your quest for better ways to regain or maintain good health. Being here on Saturday at 8 a.m. is proof of your eagerness to learn. And in my eagerness to share our knowledge with you, I overlooked that mornings are not friendly to the arthritis, so please forgive me about that. So in your bag you have some comments. Please let us know what would be the best timing for future events. I will briefly introduce you to the team of doctors today. I'm Dr. Mihaela Taylor, and I have been practicing clinical rheumatology at UCLA for 9 years. And early in my career, I learned about the East-West Medicine Center at UCLA and benefited from their treatments as I injured my back lifting my son. He's here to take pictures today. And I would say that's providential because since then I have collaborated with the doctors and professionals at the center with amazing success for my patients and for my personal health, I would say. And today Dr. Lawrence To is joining us to share from the wisdom and knowledge of traditional Chinese medicine. Dr. Ami Benarzi has joined me in practice 5 years ago after he initially started his career as a scientist at NYU. We have had a great collaboration, and we will continue to serve our patients with rheumatology conditions in Santa Monica Clinic. Dr. Steven Siderov, as a clinical psychologist and stress management expert, has helped tirelessly my patients with chronic pain to stay sane and keep smiling. And he has helped me tremendously to be able to continue after 9 years at UCLA to serve you all. So here is the team, and you are the biggest part of the team, and thank you for being here. Let's hope. So why integrative rheumatology? First of all, what is integrative medicine? Integrative medicine has been combining treatments from conventional medicine and complementary alternative medicine, CAM, having data that support safety and efficacy in clinical trials. And again, why integrative rheumatology? First of all, because arthritis is the most common chronic condition and the leading cause of disability in the United States. Conventional medicine treatments are associated with potential for significant adverse events, and unfortunately there is no cure for most of the rheumatologic disorders. 50 to 90% of individuals affected by chronic illness have used at least one form of CAM to manage the symptoms. And what is rheumatology? It's not uncommon that a patient walks in my clinic and asks me, I don't know why I'm here. I don't know if you know the definition of rheumatology, but very simple, it's a specialty concerned with diagnosis and treatment of diseases of the muscles, bones, and joints. It comes from the Greek rheuma, which means river, and is devoted to the diagnosis and therapy of rheumatic diseases. Rheumatologists deal mainly with clinical problems involving joints, soft tissues, autoimmune diseases, vasculitis. Now, what is the rheumatism? You probably all know that grandma had the rheumatism, and rheuma was hurting all over. It's any painful disorder affecting the locomotor system, including joints, muscles, connective tissue, soft tissues around the joints, and bones. So very vague. So the rheumatologist has to pull the hair and scratch his head many times because it's so vague. So going to our daily bread and butter, the rheumatologist has to navigate through the aches and pains with some tools. First, you will have to obtain a history of the illness. You perform an exam. You do a bunch of blood tests. And employ, fortunately, we have available imaging studies nowadays, either X-rays, ultrasound, CAT scan, MRIs. But still, can you tell me where is the footprint of pain in all of this? It's not easy. And before we go further, I would like to introduce you to a concept that sometimes is puzzling when frustrations occur in the clinic and the patient asks you, I don't have any changes on the blood test, my imaging tests are normal, but I'm hurting all over. So we have to understand the difference between structures versus function. What is organic versus functional or psychosomatic disorders. So I came with this metaphor for you. Let's imagine a clock and it's broken. It can be broken because there is a wheel missing. And that is the typical expression of an organic structural problem. You don't have the wheel, the clock is broken. But you may have the clock not functioning because there is no oil. And sometimes it's hard to prove there is no oil. And that is what I would find the closest to express what a functional disorder is. And we do have fantastic tests, blood tests and imaging tests to prove a broken wheel or a missing wheel, a structural disorder, but we have very little tests to prove there is a dysfunction, a functional disorder. And why that might be? Because we are still in the infancy of understanding many of our rheumatologic disorders, and it may be a dysfunctional gene or a dysfunctional chemical in the brain. So what is pain? And if I ask you what is pain, you probably will give me 100 different answers. And that's because the pain is a highly individualized symptom complex. And it is the prominent component of many rheumatologic conditions as a result of a complex physiologic interaction of central and peripheral nervous system signaling. We'll go in detail about that, but as I see one of my fellows sitting here, I want to tell him that when I took my rheumatology boards, every question started with, the patient complains of pain. It was the first time when it struck me that I went into a specialty that I have to deal with pain. During my fellowship, it has never occurred to me that I have to do that. And our training is very poor at teaching us to deal with pain. So here is central versus peripheral as medical terms that you should be aware of when we communicate with you. Central meaning central nervous system. Peripheral means every other tissue in the body, organs and systems that communicate to the brain that something is not right. And you can see here all the main organs and systems as the peripheral aspects of the pain. Another concept I would like for you to understand the difference between acute pain versus chronic pain. Acute pain is often caused by inflammation and or damage in the peripheral structures. There is something called nociceptive input, and Dr. Benartzi will talk very much in detail about this. So you can see here different aspects of very acute inflammatory situations that cause pain. Now, chronic pain, many times you find it defined as pain that has lasted more than, let's say, 3 months or 6 months or 6 weeks. Unfortunately, just equating chronic pain with the length, the duration of the symptom is not enough. We are learning that chronic pain is not acute pain that has lasted longer. it is more likely to be influenced by input from the central nervous system. So here we come with understanding how the brain influences chronic pain. The prominent role of the central, again, the brain, factors in chronic pain is highlighted by the fact that there is currently no chronic pain condition in which the degree of tissue inflammation or damage alone accurately predicts the presence or the severity of pain. As I mentioned earlier, the frustration that no X-rays, MRIs can tell you that pain severity is reflected by this structural type of imaging or testing. And to give you an example here, osteoarthritis has been viewed primarily as damage to the cartilage and bones. As such, the magnitude of damage or inflammation of these structures should predict pain intensity. Let's say you have what we unfortunately sometimes call bone-on-bone joint arthritis. The knee has lost the cartilage and is bone-on-bone. Does that predict the level of the pain? No. The paradox is that 30 to 50% of individuals with moderate to severe radiographic changes of osteoarthritis are asymptomatic. They have no pain. I have a marathon runner that has no cartilage, and her orthopedics for the last 10 years is pushing her to have joint replacement. But she has no pain, and she keeps running. And you have 10% of individuals with moderate to severe knee pain and normal findings on the X-rays. So again, we are going back to the fact that pain is a highly individualized complex, depends on the perception of the individual. So to give you a little bit of a metaphor about how brain interferes with the perception of the pain, I have put here a beautiful Syrian lake that receives a pebble that causes these ripples. That's the painful stimuli coming from whatever you want to, an elbow or a shoulder. And the brain has checks and balances that minimizes that ripple effect and keeps it localized to the area where it has started. And it limits, and when that painful stimuli is gone, you have no more pain, you sense no more pain. Unfortunately, in situations where that painful stimuli has been repeated over and over again, and I have here this bombardment of painful stimuli to the brain, or in certain individuals that Dr. Benartzi will mention that have an hyperalgesic state, they are more sensitive, and the gate opens from the periphery to the center. The brain is under 24/7 stimulation by this painful stimuli, and no more state of peacefulness. Look what happens, you get a storm. The brain has lost the checks and balances, and the painful stimuli are spreading wide across the cortex of the brain. So that is causing central pain. So this is a relatively new concept of centralized pain that my patients coming into the practice are complaining about, and here are the words taken from the chart. I feel like a truck ran over me. I hurt head to toe. My bones hurt, my muscles hurt. The pain is so deep. My muscles are hard as a rock. I feel like I carry cement on my shoulders. My skin is burning. Nothing helps. You see the component of helplessness. I cannot think, brain fog, cognition impairment. I cannot sleep. The sleep becomes disrupted. I am exhausted all the time. The fatigue is settling in. So another of my favorite metaphors to explain when the patient comes with all these frustrations, how does centralized pain feel like? I say it's like this broken radio. It used in your 20s to play a beautiful symphony, and now a screechy loud noise 24/7. What happens if you are exposed to such a sound 24/7? You cannot sleep, you cannot think, you get angry, frustrated, tired, irritable, and you start hurting all over. Now, the other side of the coin, how centralized pain doesn't feel like. And here are the patients that come and tell me, I blocked out the pain. I powered through. I have been on automatic pilot for 30 years. I cannot have fibromyalgia because I do not have the tender points. So I give them this other metaphor of the cake with many layers. And we start treating the neck pain or whatever localized pain that the patient comes with. I have a patient that complained that her feet are hurting and there was nothing else wrong, and put me on the wrong track for a while. I was looking for psoriatic arthritis and all sorts of other organic, let's remember again, structural problems, when it was all the time fibromyalgia, functional disorder, central pain. So in my simple metaphor here, I want to tell you that the brain can cope with one pain at a time, let's put it this way. And once you take the first layer out, another layer is surfacing. I'm injecting a knee for osteoarthritis and the other knee doesn't hurt. And the next week, the one that was injected feels better, but the other one all of a sudden decided to hurt. So we go and inject the other one as well. Remember, you have to have the awareness of your body, and we'll talk later about mindful awareness. Now, finally, the American College of Rheumatology has come with preliminary diagnostic criteria for fibromyalgia that are not required to have the presence of the tender points. And I think this captures that group of patients that I mentioned earlier that cannot express their pain. And when you do the tender points exam, they say, no, I do not have them. But the pattern of central pain with fatigue, insomnia, and brain fog, it's all there. So I know they have fibromyalgia, but they put the paper in front of me and they said, I don't have tender points. You are not good, doctor. So here we have a little relief of my frustrations. Because now we are not required to have tender points, but we are required to have widespread pain for at least 3 months associated with fatigue, waking unrefreshed in the morning, and having cognitive symptoms. And we had added now somatic symptoms to this initially very much musculoskeletal oriented diagnosis of fibromyalgia. And if you look at the very fine print here, I don't know if you can read it, you don't have to read it, because I'll tell you a few pointers here, is including now in these somatic symptoms migraine headaches, irritable bowel syndrome, diarrhea, dry mouth, itching, wheezing, ringing in the ears, all kinds of somatic symptoms that patients experience, but the rheumatologist, when he presents, oh, don't tell me about that, deal with the gastroenterologist, or with the neurologist, or with the ENT. And patients, of course, feel not attended to because they do experience all these symptoms as part of the central pain syndrome. And I made a red line there to the fact that we do have to exclude an organic disease before we come down to the diagnosis of fibromyalgia as a functional disorder. Again, remember the clock with the missing wheel, organic versus functional. So I have to rule out that for these complaints of abdominal pain, there is not a tumor. For these complaints of pain in the joint, there is no inflammation that will lead me to a diagnosis of rheumatoid arthritis, and so on. So again, the message here for you and for my fellows is that fibromyalgia is here to stay with the rheumatologist, because although it is very likely a dysfunction at the nervous system level, will not be treated by the neurologist, because the neurologist will not be able to exclude all these other rheumatologic conditions that can cause aches and pains. So is that a good message for the fellows? So what footprints the central pain leaves behind? What can help us in making the diagnosis of central pain? Occurrence of multifocal pain in conjunction with other centrally mediated symptoms such as fatigue, insomnia, memory difficulties, and mood disturbances. In central pain stage, several neurotransmitters levels are abnormal, and Dr. Benartzi will talk about that in detail. And I know that he's looking at the clock now and says, "Move on, Dr. Taylor, because I'm behind. I have 60 slides." So the hallmark biologic finding common to this centrally driven condition is that most individuals have a diffuse central nervous system hyperalgesic state. And this has been finally demonstrated by functional studies. Look at that. They are in the research phase. We don't have them in clinical practice, but we are making progress from that organic structural type of studying of the body to the functional studies. And that is, for example, a quantitative sensory testing and functional brain MRI. So we know now that hypersensitivity to the non-painful stimuli in sensitized pain patient is the hallmark of chronic pain. And here is the historical description of fibromyalgia in The Princess and the Pea. And the princess had fibromyalgia. So what does your doctor has to ask here about centralized pain? In case of the new onset of regional pain in individuals with hyperalgesic state, the princess, closer questioning often reveals that they have had many different regions of chronic pain over the course of their lifetime, or even at present. They may complain just about that one joint, but ask and you will be surprised. There are many areas where they hurt, but their brain has blocked out that pain. There is often family history of chronic pain. There is strong role that certain genes play in turning up the gain on pain processing and in identifying one cause of chronic pain-prone phenotype. So one such gene is called an estrogen-sensitive enzyme. Bingo, estrogen-sensitive, that may play a more prominent role in females. So I will not go in speculation here, but I'm sure that you all know how the hormone level plays on the level of pain. So here is our princess, not happy. And as you can see, the pain-prone phenotype is mainly a female gender. The genetics, I mentioned earlier, the family pain history. Early life trauma is a major one. There is sometimes family history of chronic pain and mood problems. And there is personal history of chronic centrally mediated symptoms. Again, fatigue, sleep disturbance, psychological distress, memory difficulties. And there is a tendency in this phenotype of catastrophizing. Welcome to the club. I am guilty of that. Lower mechanical pain threshold and descending analgesic activity. This is something that Dr. Benartzi will talk very much in detail in his fibromyalgia talk. So I'll move on and make the point that psychological and behavioral response to pain or stressors are a major part on how we get to this level of distress. And Dr. Siderov will give you a wonderful talk on that. So what about this question? My rheumatologist doesn't believe in fibromyalgia. What will you do? Tell him it's not a religion to believe or not believe in it. This is what my attending told me in my fellowship, and he has followed me since. And really, in my fellowship, I was not sure about this. Should I believe or not? I don't know. But practicing, you really cannot dismiss it. It's there, it's in front of you, and it's part of our daily practice. And the problem with it is because generally the rheumatologist finds a normal physical exam, except for this diffuse tenderness and very non-specific neurological signs. So if he doesn't take a good history and gives the patient 100% credit to the symptoms, he will be the non-believer. And you will have to either find a new rheumatologist or come with this paper and educate him. Or her, sorry. So, as with most illnesses, they may have a familial or genetic underpinning. Environmental factors may play a prominent role in triggering the development of fibromyalgia and other centralized pain states. Environmental stressors temporally or chronologically associated with the development of widespread pain include early life trauma, physical trauma, certain infection such as hepatitis C or Epstein-Barr virus, parvovirus, Lyme disease, and let's don't forget emotional stress. Frida Kahlo very likely also suffered with a rheumatologic condition and fibromyalgia. You can tell from her paintings how much pain she was during her lifetime after that terrible trauma in her childhood in the bus accident. Rheumatologists have known for some time that as many as 15 to 30% of individuals with classic autoimmune or rheumatic disorders, such as lupus, rheumatoid arthritis, osteoarthritis, also have comorbid fibromyalgia. This has been referred to as secondary fibromyalgia. These rates are much higher than the 2% prevalence of fibromyalgia in the general population, suggesting that long-standing pain and or stress accompanying chronic illness is one way that conditions such as fibromyalgia can be triggered. Fibromyalgia is a common comorbid condition in lupus and confounds both the diagnosis and treatment of lupus. Neither the degree of inflammation nor the degree of damage is highly associated with the pain, fatigue, and function of or other symptoms of lupus. The presence or absence of comorbid fibromyalgia is often the largest predictor of pain, fatigue, and function in patients with lupus. The presence of fibromyalgia in lupus is most closely associated with fatigue, sleep disturbance, psychiatric disturbances, and work disability. So fibromyalgia in lupus is an ingredient that we cannot ignore. There is one single published study that has used functional neuroimaging in lupus, and the areas in the brain that showed diminished blood flow that were seen in patients with lupus without fibromyalgia overlapped with those seen in patients with fibromyalgia alone, as well as in patients with lupus and fibromyalgia in combination. So I put here a bread and the ingredients. You slice the bread, you don't get back to the ingredients. It's all intertwined. It's all there together. They are the same paths that lead to the central pain. Doesn't matter where it started. Rheumatoid arthritis and fibromyalgia. In contrast to fibromyalgia and osteoarthritis, rheumatoid arthritis is characterized by systemic inflammation. Although inflammation contributes to pain in rheumatoid arthritis, it may not be the only factor. For many patients, pain does not improve when you treat with specific anti-inflammatory disease-modifying agents that target the inflammation. Wolf showed that fibromyalgia is very prevalent in rheumatoid arthritis patients and there is increased morbidity in patients that have both rheumatoid and fibromyalgia. Lee and colleagues recently showed that in rheumatoid arthritis, the relationships between inflammation, psychosocial factors, and peripheral and central pain processing are intricately entwined. So again, think of the bread and the ingredients. You can separate them at one point. There was a study that showed that people that have inflamed joints with highly elevated C-reactive protein levels reported the pain being strictly in the joints. But in that study, the sleep disturbance was associated with pain thresholds in both joint and non-joint sites, the way fibromyalgia patients experience between the joints the pain, which indicated that there is central pain mechanism that comes aside of the peripheral, the joint inflammation that causes the pain. What are some future directions that we have to pay attention now that we have more or less described this central pain syndrome? Patients with osteoarthritis, rheumatoid or lupus, whose pain has already become centralized, may be less responsive to classic peripherally directed pharmacologic or surgical interventions. So the doctor is frustrated because the patient doesn't respond to the prescription medications. And there is a reason for that, because we have forgotten about the central pain. 20 to 40% of individuals receiving arthroplasty and other surgical procedures performed to relieve chronic pain continue to have significant knee pain at 1 to 2 years. And they go and blame the surgeon, and the surgeon says, "It looks fantastic, go to your rheumatologist." And he is right. His job is done. But unfortunately, somebody failed to recognize the central pain before entering the surgery. So nobody is happy now. Across the rheumatic disorders, individuals with higher degrees of fibromyalginess, that's a new term also, may preferentially respond to centrally acting drugs, meaning you go after the central pain, not by replacing the joint. You have to use antidepressants, gabapentinoids. Dr. Benarti will give you all of that knowledge. The overall direction of chronic pain research is a paradigm shift in the diagnosis and treatment of pain in individuals with rheumatic disorders. And this is good news because although most patients seen by rheumatologists have pain as their presenting complaint, most rheumatologists have little formal training about contemporary theories regarding pain processing or pain management. Because of this, educating rheumatologists and others involved in the care of individuals with musculoskeletal pain has become a priority, and the American College of Rheumatology Pain Management Task Force has highlighted this in an initiative to increase awareness and call for organized research and education concerning chronic pain. So we are making progress. This is very recently published, February of this year. And another future direction that I may add, it's a new vision of health. I came across this and I really like it. And I have strived in my practice to consider health not just lack of disease, A healthy system implies much more than freedom from disease. Vitality, appropriate feelings, appropriate thought process, a willingness to embrace change in our lives, creative self-expression and responsibility, intuitive understanding, healthy spiritual relationship are all essential if we are to be full of life and well-being. And next retreat will be in Machu Picchu. So I put that there because we'll be changing gears in another area that is pretty challenging. So what is autoimmunity? Simply said, immune system attacking self. I looked in the Wikipedia and here is what we have as a definition. Autoimmune diseases arise from an inappropriate immune response of the body against substances and tissues normally present in the body. I said inappropriate because a lot of people coming in the office, they say, my system is hyperactive. It's not about hyperactivity, it's about dysfunction. Loss of immunological tolerance, which is the ability of an individual to ignore self. That's another good definition of autoimmunity. Loss of tolerance to self. In rheumatology, a majority of the autoimmune disorders are clustered under the name of autoimmune connective tissue disorders or collagen vascular disorders. And here I put a sample of the autoimmune diseases that the rheumatologist has to diagnose and treat. So I'll give you a quick immunology lesson now that you are all awake. And we'll start with the very simple role of the immune system, surveillance and defense against whatever is foreign. So if you would envision, and I don't like necessarily this metaphor, but it works, unfortunately, we have to envision as an army the defense against foreign invasion. Here is the foreign target or antigen. It can be a virus, a bacteria, or a cancer cell. The antigen-presenting cells that are part of our innate immune system will recognize this as foreign versus self and will take it to the next cell, here a T cell, and the T cell will start putting out a line of defense that it's called cytokines. This is like a biochemical weapon or a biological weapon. Will kill the enemy but will sicken their own people. Meaning these cytokines are the basis of inflammation. Think when you have the flu, you are getting chills, muscle aches, malaise, fatigue. All are the result of this storm of the cytokine release. Also the T cells will tell B cells to be on standby here to make a more specific defense against the foreign, and that is called an antibody. And an antibody, you can envision it as a missile, and it goes straight after the foreign antigen and neutralizes the foreign attack. There are many proteins involved in this complex, and one is complement. This is also called an immune complex. It is based on the principle of lock and the key. We can make billions of antibodies to billions of antigens that we are being exposed daily. Very amazing stuff. So what happens when there is a dysfunction in this perfectly miraculously balanced immune system? In this case, the B and T cells will be attacking self with the same weapons that they use to defend the organism against the foreign invader. So you can imagine now that this cytokine storm that are causing inflammation, fever, malaise, joint pain, muscle pain, are ongoing in the body of a patient with lupus or rheumatoid arthritis without having the outside foreign trigger. Now this foreign trigger is becoming your own cell. And here is your own green cell being under the attack from B cells with autoantibodies. And that attack is leading to all kinds of damage in the peripheral systems, joints, lungs, heart, but also we are learning in the brain. So, what are environmental triggers of autoimmunity? I guess this will be our next talk, because I will be here for the whole day. But let me give you a quick review. Why is this dysfunction happening in the immune cells? We know genetics play a role, but we also know environment plays a role. And I put there at the top stress, physical or emotional, smoking, infections, sleep deprivation. Vitamin D deficiency is potentially now being linked with dysfunction of the immune cells. We'll talk about the vitamin D. Again, the jury is still out, but there is enough smoke for the fire not to be there. So the immune system lesson is that everything is connected. There is overwhelming evidence that nervous system, through neuro-immune and neuroendocrine connections, can influence the activities of the immune system. So if you wonder how that stress is causing the flare of the dermatomyositis and the lupus, in hours from the stressor, it may not be that surprising, because there is a lot of basic science research that shows how there is a crosstalk between the brain and the peripheral immune organs, such as a lymph node or a spleen here, showing all of these T cells and the cytokines that we mentioned earlier, trafficking back and forth. The nervous system receives information from the immune system in the form of these chemicals called cytokines, and they can cross the blood-brain barrier. There was a dogma that there is no talk between the immune system and the brain, and that dogma in the last few decades has been falling. But we still do not have a lot of proof in clinical trials in humans to show, imagine it's very difficult, that connection, but there is a lot of data in basic science. Inflammatory cells also can cross the blood-brain barrier and bind on the central nervous system's neurons and produce cellular responses that change the activity of the neural circuits in the brainstem and in the hypothalamic nuclei, which control the autonomic nervous system and the neuroendocrine system. I want you to remember from this slide the autonomic nervous system, because Dr. Sidorov has a big talk about how stress and physical disease are connected. So, of just anecdotal interest here, there is an attempt to control inflammation in rheumatoid arthritis, not by taking a pill that targets the inflammation in the joint, but stimulating the vagus nerve. So this was an open-label pilot study focused on rheumatoid arthritis that suggested that by stimulating the vagus nerve using a commercially available neuromodulation device, the inflammatory reflex can be regulated to improve clinical manifestation of rheumatoid arthritis. So this is one of the new studies proving the link between arthritis and the brain. Now, what about vitamin D? It's everywhere, every newspaper you open, every show you watch, everybody talks about vitamin D, placebo or panacea. So you decide. As I said, the jury is still out. I'll give you some information here. Vitamin D deficiency is highly prevalent in the general population. During winter months, 50% of population in Northern Hemisphere are vitamin D deficient. Normal vitamin D levels are hard to define as there is significant inter-individual variation. Again, keep that in mind, individual variation. Vitamin D deficiency is defined as serum 25-hydroxy D levels less than 20 nanogram per milliliter, and insufficiency as serum 25-hydroxy D less than 30 nanogram per milliliter. These cut-offs are determined by the effect of the vitamin D on parathyroid hormone levels. But again, a lot of inter-individual variation. Vitamin D deficiency has been linked to several autoimmune diseases, including type 1 diabetes, multiple sclerosis, systemic lupus, and rheumatoid arthritis. Vitamin D regulates both the innate and adaptive immune responses. If you remember the antigen-presenting cell, the B and T cells, those are the cells we are talking about. We now understand that vitamin D, it's a hormone. It's a steroid hormone. It's manufactured from cholesterol. And it has a lot of effects, aside of the classical effects related to the bone metabolism. So we are learning that, amongst other things, it has possible effects in cancer, metabolic syndrome, immune disorders, and dementia. Now, I think I will skip these slides about the metabolism of vitamin D. I just wanted to show it here that there are few organs that intervene in the classical metabolism of vitamin D. Skin, you all know that if you stay in the sun, you make vitamin D in the skin. In the liver and in the kidney, there are few other steps in the metabolism and making of the vitamin D. There is an enzyme that helps this process of making the vitamin D. And just to puzzle you here, this enzyme that contributes to the final active form, which is the 1,25-dihydroxy-D, binds to the nuclear vitamin D receptor and regulates the transcription of more than 200 genes. So this is not just a simple, let's say, small wheel in the clock. It's a major one. Even though the simple wheel missing can make the clock stop working. So also we are learning that this enzyme is found in multiple cell types, not just in the 3 organs that I showed you initially. It's found also in the lung, in the colon, in the immune cells, in the bone cells, and these cells can locally generate active vitamin D and control its metabolism. So the finding of this receptor also indicates that these cells are dependent in their function on the vitamin D. So we have here a couple of studies that showed benefits in rheumatoid arthritis from supplementation of vitamin D, and as you see here, a very large one with 1,200 rheumatoid patients in Italy showed that daily sun exposure, quantified in minutes, correlated with disease remission, treatment response, and the swollen joint count. Now, unfortunately, there are a lot of variables that can make a study difficult to prove that there is a direct link between vitamin D deficiency and the rheumatoid arthritis activity. Because in rheumatoid arthritis, there is a higher BMI and there is also sedentary lifestyle that can contribute to lower outdoor activities that can cause vitamin D deficiency. But it may be an intrinsic defect in the metabolism of the vitamin D in rheumatoid arthritis and in the state of inflammation. We are just discovering that, but it is very hard to prove because of all these covariables. So there are several studies that look at the association of vitamin D deficiency in rheumatoid arthritis that didn't show that it is beneficial for the disease activity. So my message to you is, when the jury is still out, use the common sense rule. When something is off balance, let's restore the balance and see what happens. And another important rule in therapeutics, when my patient comes here and she allowed me to take picture of her supplements that she was taking from her naturopath, first, do no harm. So my usual answer is, if these appear to be safe, it's fine. But unfortunately, we do not know many times what safe means, and also it's very highly dependent on the individual. That's the reason in the Western medicine we are so cautious with using all these supplements, because we do not have yet the proof of their safety and efficacy. So that brings us to the complementary alternative medicine, the CAM discussion. And that, as a definition, refers to a group of diverse medical and healthcare systems, practices, and products not generally considered as part of conventional medicine. That's the Western medicine I was just talking about. On the other hand, that which may be considered to be CAM is influenced by political, social, and cultural issues and the dominant healthcare system. So in China, traditional Chinese medicine, I'm sure is mainstream. And I cannot stop not telling you this. Yesterday, one of my patients that I encouraged to go and have water therapy for her fibromyalgia said, yes, I'll be there with all that Russian ladies. I said, yes, because the Russian ladies have learned from their babushka grandmother that water therapy is very healthy for you. But here, it's not necessarily widely accepted that you should treat yourself to a spa or massage. So what about mind-body medicine? Even a shakier land to prove that working on the brain can make an individual feel happy. So we just have to look at Bob Marley, and he said a very good thing. Music, when it hits you, you feel no pain. So I think music therapy is something we should consider. And of course, other outlets, dance, meditation, prayer, they are still considered CAM, but you can all be witnesses that they do good for you. Now, previously considered CAM, now are mainstream. For example, patient support groups, cognitive behavioral therapies. In the past, were considered voodoo. And now we are having them as our tools for everyday care. Ami, don't kill me, I'm almost there. Meditation. So that incorporates a diverse range of techniques that help to focus attention and bring a state of self-awareness. If you remember, I mentioned that self-awareness to your body and, of course, to your emotions and your mind. There are two major categories of meditation practices: concentration meditation and mindfulness meditation. There are few trials that have tried to see if there is a link between use of meditation and benefits in treatment of rheumatologic disorders here in rheumatoid arthritis. For example, one trial tested meditation for 8 weeks against a waiting list control group. Although they didn't find significant difference between the two groups in the disease activity scores, by 6 months, psychological distress and psychological well-being were improved to a significantly greater extent in the meditation group. So at present, there is no sufficient evidence from the randomized controlled trials of effectiveness or efficacy in the management of rheumatoid arthritis, but I think the story is still to be unfolding. Now, mindfulness, it's a type of meditation that involves non-judgmental observation of sensation, thoughts, or emotion, and is concerned with the cultivation of moment-to-moment awareness during the meditative process as well as in everyday life. So, in 2003, this study focused on how an 8-week training course would affect the brain and immune system of individuals. And this investigation provided some evidence of increased activation in the region of the brain correlated with positive affect, as well as evidence that the immune system will react more robustly in antibody production after meditation training. And I am here after the stress of preparing this seminar on top of my work as a witness that there is a link between stress and immune system, because last night I got the cold and I'm losing my voice today. So, Mindful Awareness Research Center. It's a fantastic resource at UCLA, and in your bag you will find a flyer with their seminars and activities that are starting, I think, July 8th. So please look into that. I will have 1 minute left for the talk on exercise, but there is not much to talk about exercise. You all know improves oxygen delivery and metabolic processes, builds strength and endurance, decreases body fat, improves movement in joints and muscles. So we all know it's fantastic. But the problem is 1/2 of all people who begin a training regime drop out within a year. And that's me. That's me. So the key is to make it exciting, challenging, but don't forget, be safe when you exercise, particularly when you deal with arthritis. So there are a few simple rules. Don't eat before you exercise, drink plenty of fluids, and adjust activity accordingly. So that's the problem, that I drop all the time my good intention of exercising because I feel tired and catching a cold every weekend. So don't overdo it if you feel sick. So I learned the hard way. When exercising, listen to the body. That's the key message here. Warming up and cooling down periods are important. They aid the body in making the transition from rest to activity and prevent soreness or injury. Low-level aerobic exercise is the best approach, so walking, briskly swimming, probably the best for people suffering with arthritis. Stretching is appropriate for the cooling down. You see a lot of people stretching before they start exercising, but that's where there is the highest risk that you can injure a cold joint or a cold muscle. Joints require motion to stay healthy. Use it or lose it. Long periods of inactivity cause the arthritic joint to stiffen and the joining tissues to atrophy. A moderate exercise program that includes low-impact aerobics, power, and strength training probably is the best combination for arthritis. And again, very obvious benefits from exercise: reduces stiffness, increases flexibility, is critical component for the weight loss program, and improves strength, which in turn improves balance and endurance. Also, let's don't forget about the well-being and the reduction in stress that you have, and that will reduce the emotional burden of pain. Range of motion exercises increase the amount of movement in a joint and muscle. In general, they are stretching type. So Tai Chi is gaining a lot of popularity, and it has been added to the therapeutics of osteoarthritis. So now we recommend Tai Chi. You have to be careful yoga. Usually you have to tailor it to your own needs. So low impact workouts are very important for people with arthritis. Again, high impact sports should be avoided, and I had very hard time convincing a patient that was a marathon runner that he should switch now to bicycling. We have to adjust. We have to adjust. So the message on this slide is that strengthening the leg muscles, for example, in osteoarthritis of the knee, should be the first treatment step before using pain relievers, because there is a fear that patients who rely on pain-killing drugs may overuse the knees, which do not have muscle tissue sufficiently strong enough to protect the joints from further damage. Again, more and more studies proving the same thing. The exercise leads to less disability and pain. And where the healthy mind in the healthy body comes from, I researched it during this talk, and I found out that this aphorism comes from the Latin satirist and poet Juvenal, and in his 10th satire, you can see here that he emphasizes that a healthy body leads to healthy mind and the other way around. We have to have a healthy mind for a healthy body. Again, it's all connected, and we'll see Dr. Sidorov convince that further later today, if we get to your presentation, Stephen. And we will, because this is my very last, almost the last slide. Oh, I had more than 60. So we have a take-home message for you. You have to be active participant in your own health. And one of my patients, I will not look exactly where she is sitting now, sent me this email sharing from her experience with arthritis. And she says, one of the biggest problems I have found is that there is not a one-size-fits-all treatment for the disease. My point, each person has a different set of physical issues to deal with regarding any kind of physical activities, and you must be your own advocate. So my message here is that we should try to practice more preventative medicine. And this is a favorite quote to my patients that come once a year to see me when they cannot walk or they cannot think anymore. I said, don't wait for the house to be on fire. Please come and see me when you are healthy. And happy, of course, will make me feel better as well. Not hearing every day pain, 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 nothing works. And chronic illness is like becoming a parent. This struck me one time driving to work. But this time, you are both the parent and the child. Use lots of tender love and care, and set healthy boundaries for yourself. So treat yourself the way you would treat your own child. How many of you do that? Me? My son left because he has a piano lesson, but when he was 5, he asked me this. And really was a big wake-up call and awareness to what I was doing. He said to me, Mommy, do you love yourself? And I was speechless. And he continues, you take care of everybody, but you don't take care of yourself. So here you are, coming and joining the club. So this is my last slide. I want to thank you to all my teachers. There are too many to put them down here. But I want to thank to my patients who are teaching me every day resilience lessons and who inspire me and challenge me in my work and my personal growth. So thank you all for teaching me and for learning together.